Hello everyone, this is Dr. Saroj Siddiqui from the platform of UKMLA with DSS. So let's just begin and let's just continue our psychiatry stations. And today what we're going to study is how to understand what the depression case is and how does it typically present and what you need to make sure and what you need to do in order to diagnose it correctly and make sure that you don't panic and make sure that you don't lose your calm and lose your control in the depression stations. Okay, this is because the depression stations can be particularly difficult to manage, and the reason why it can be difficult to manage because what they do is that they don't give you the typical symptoms of depression. Okay, they're either going to give you insomnia, either they're going to give you tiredness or weight loss. Okay, symptoms which are not typically for depression. Okay, yes, insomnia can be there in a depression patient. Yes, tiredness can be there in a patient who is depressed, and the patient who is depressed can also have a weight loss. But all of these presenting complaints that I just mentioned and I just highlighted, depression is not the topmost differential. Okay, like for example, if somebody is coming to you with a low mood, okay, you would know that okay, if he's having a low mood, it's most likely to be depression. Okay, low mood can be because of a lot of issues. It can be because of a schizophrenia as well. It can be because of an abuse as well. Okay, it can be because of chronic diseases as well. But still, depression would be something a differential that you would rate very high. Okay, and it would be one of your top differentials. But the atypical symptoms like insomnia, tiredness, weight loss, that is those are the symptoms in which you think about depression as the very last differentials, and that is the reason why I have mentioned it in the very end. Okay, so you need to be aware of the fact that okay, the GMC can give you and can expect you to come to the diagnosis of depression while giving you these three symptoms. Okay, so it can be particularly tricky. Okay, because these three symptoms are like so non-specific symptoms. Okay, and they are overlapping so many different diseases, and where it gets confusing is because there is another differential that these symptoms have is the abuse. Okay, a patient of abuse can have insomnia. Okay, a patient of abuse can also have tiredness. Okay, so now you see there are like three different categories of PLAB2. Either it can be just a basic history taking station, okay, in which you just have to talk about the organic cause and give an organic differential. Okay, so in that particular case you would have to follow the medical history taking approach. Okay, or it can be an abuse station in which you may have to change your approach from a medical history taking to a abuse scenario, to the abuse cases and the structure that you need to follow for the abuse cases. Okay, and then it gets further complicated because depression is also one of the differentials, and if it's not abuse, if it's not an organic cause, then it's most likely to be depression, and then depression has a completely separate way to go about it. It is a completely separate structure that you need to follow. Okay, so like what most of the candidates do, because they're not very well aware of the fact that depression and abuse can present as insomnia, tiredness, weight loss. Whenever they see these symptoms, they take a very close-minded approach. Okay, and that close-minded approach is that okay, they think that okay, there can be only organic causes. Okay, and we're just going to rule out the organic causes. Okay, but that is not the way to go about it. That is not the right way to go about it. So whenever you see insomnia in a case, whenever you see tiredness in a case, whenever you see weight loss in a case, okay, whenever you see these three cases or these three symptoms, always make sure that okay, there can be three sets of things. Number one, organic causes, number two, abuse, and number three, depression. Okay, so the abuse and depression always needs to be there in your differentials. Okay, now I'll tell you that what you need to do. Number one, do not just stick to the organic causes, because if you do that, you're going to spend 6 minutes just asking questions on organic causes, and you would not be able to reach out, and you would not be able to reach to a particular diagnosis. Okay, the examiner and the simulator will just keep on like giving you vague answers and confusing you, and you will never be able to come to the right diagnosis. Okay, so number one, the first step that you need to take after you're done with the introduction and the rapport building, you need to rule out the organic causes as soon as possible. Okay, now why do I say that? Because if you directly ask the questions about abuse, if you directly ask the questions about depression, as soon as you hear the word insomnia, tiredness, or weight loss, you're going to sound extremely scripted. Why am I saying this? Because as I mentioned, that depression and abuse are, the differentials that are kept in the end. All right, so you need to have them in mind. But if you start asking about them in the very beginning, you would sound very scripted, because the examiner will get an idea that okay, he or she knows that we give depression or we give abuse with these symptoms, so that is why he's just asking it for the sake of asking it, and he just knows what the script is, and he knows what the case is. Okay, and you don't want to give that impression. Okay, you don't want to be scripted. So what you need to do is that just very quickly first try to rule out the organic causes, and you should be very well aware how you can rule out a cause by just asking a couple of questions. Okay, and these questions needs to be there on your fingertip. Like for example, if somebody is presenting to you with insomnia, you got to explore the sleep hygiene. Okay, and how you're going to explore the sleep hygiene, that okay, can you please tell me that the place where you sleep, is it comfortable? Do you have a comfortable pillow? Is it noise proof? Do you sleep with lights on and lights off? Okay, just a couple of questions of sleep hygiene. And then you can explore the sleep as well, that okay, regarding insomnia, can you please tell me, are you having difficulty in initiating the sleep or falling asleep, or do you have difficulty in maintaining the sleep and then you wake up in the middle of the night, or do you have problems in waking up early? So you gotta explore the insomnia, and you gotta explore the sleep hygiene, just to make sure that you are touching on the organic cause. Then obstructive sleep apnea, you're going to ask about that. Okay, by any chance that while sleeping, do you feel any shortness of breath and you wake up, or do you snore excessively when you are sleeping? So just two questions to help you rule out the diagnosis of obstructive sleep apnea. Okay, in a very quick way. Then hyponatremia, you can ask about muscle spasm that may be associated with hyponatremia. Dizziness and confusion may be associated with hyponatremia. Okay, for anemia, you can ask about the diet. You can ask about shortness of breath on exertion. Okay, for chronic fatigue syndrome, you can ask that. Okay, do you feel tired all the time? Okay, do you feel that you do not have the energy to do even a single bit of your daily activity? Okay, cancers can be ruled out by asking about the weight loss, but if the symptom itself is weight loss, then you may rule out cancer by asking about any lumps and bumps in the body. You can ask about thyroid disorders, yeah, by asking about the bowel movements, by asking about the mood, by asking about cold and heat intolerance. Okay, so just a couple of questions, just to make sure that you are ruling out the organic cause first. And one very important tip: you should not be taking more than a minute and a half for this step one. Okay, your step one should be done in not more than 90 seconds. Okay, just get rid of the organic cause as soon as possible. Okay, and if you find that and one of the organic causes or the questions that you ask about the organic causes is positive, then of course, like, you would change your approach and get to the medical history taking approach, because it would show that yes, this is a medical history taking station. But if it's a classic depression station, you're gonna get the answer no, 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 for every organic cause that you're trying to rule out, and for every differential that you're trying to rule out. Okay, so that is the very first step to go about it. Number two, so now you show that okay, this is not an organic cause. So it's either abuse case or it's either a depression case. And in the first lecture of psychiatry, I talked about the fact that all the abuse cases and all the psychiatry cases, maybe all, but most of the psychiatry and the abuse cases, they may give you non-verbal clues. Okay, so the non-verbal clues would be there. Okay, it's most likely to be there, even in a depression patient and even in the abuse patient. Okay, they will be having this kind of a posture, bent elbows, leaning backwards, not making eye contact, having a very low tone, and maybe fidgeting with the hands, and just showing a very dull face, okay, and not being energetic, okay. So you need to identify and validate the non-verbal clues, okay. In this case, that okay, I can see that you are being uncomfortable, and let me tell you that this is a safe space, and whatever we discuss will remain confidential, okay. So you got to rule out the uh, possibilities of the organic cause first, then identify the non-verbal clues and validate it just like the way that we discussed. I'm not going to go into a lot of detail, okay. The step 3 is that before coming to depression, okay, you need to ask about the abuse, okay. Before depression, rule out abuse, okay. Very very important. And how you're going to do that, that as soon as you signpost that I can see from my I can see that you're being uncomfortable, let me tell you that this is a safe place and whatever you will discuss will remain confidential. And then you use this sentence, that by any chance are you experiencing anything, is anything making you feel overwhelmed that you want to talk about, then please let me know. I'll try to help you in the best way I can. Okay, so as soon as you ask this question, if it's an abuse scenario, the patient would nod, or patient would say, "Yeah, doctor, something traumatic has happened. Yeah, doctor, this is something I want to talk about." So you would immediately know that okay, this is an abuse station. I need to follow the abuse structure. But if it's not an abuse station, then you have ruled out the possibilities of all the differentials. This is not an organic cause. This is not an abuse. Then the only thing that it can be is it's depression. Okay, so if on step number 3, if they say that doctor, no, nothing is wrong, nothing is disturbing me at the moment. It's just that my sleep is disturbed. It's just that I feel tired all the time. It's just that doctor, I've been losing some weight, and I'm kind of concerned about it. Okay, so you would know that okay, this is most likely going towards the depression side. All right. So you need to follow this step. The organic cause first, non-verbal clues, signposting, then ruling out abuse possibility, and then once you're done with this, okay, very important layer. This first layer is like really important. Uh, I would advise you to at least spend three and a half minutes on this entire first layer exploring the presenting complaint, because it is very complicated. Three different structures, three different possibilities, 7 to 8 different differential diagnoses that you need to play with. So it's kind of challenging, and you should give this layer the respect that it deserves. Okay, try to give this layer some time, because if you give this layer the time, if you're able to come to the right diagnosis, rule out the other differentials, then the rest of the session would become very easy for you. Okay, so till here you would know that okay, this is depression, and now you will automatically move on to the layer number 2, which is the depression specific history. Okay, now let's just go back to your knowledge of lab 1, okay, or your medical knowledge. uh, you must remember the DSM-5 criteria. Okay, so it's a big criteria, but I'll just shorten it down for you. Okay, the criteria to diagnose depression is basically number 1, anhedonia. Okay, and now what does it mean? It means that the patient may not be having the interest, or patient may not be showing interest in the activities that previously used to excite the patient before. Okay, that is the first question that you need to ask. Okay, that is the first and the foremost criteria. Okay, that do you feel that you don't get excited, or you don't feel the pleasure in the activity that used to excite you before. Like for example, somebody may be very fond of gardening, and it was something which was their hobby, but maybe that is something that it doesn't excite them. Maybe somebody was excited about a football match, somebody was very excited about playing cricket, somebody was very excited about any particular type of sport, but it maybe it doesn't excite them anymore. Okay, so ask about anhedonia. That is the very first question that you're going to ask. Okay, the most likely question answer would be yes. Okay, then can you please rate your mood on a scale of 1 to 10? All right. This is again a kind of a non-specific question, because low mood can be there in anything. It can be there in abuse. It can be there in chronic stations. It can be chronic conditions. Okay. It can be in other psychiatry stations as well. But you've ruled out the possibility of abuse. You've ruled out the possibility of other organic causes. and the patient is showing the signs of anhedonia. So all of these things with the signs of anhedonia and low mood, that further solidifies your diagnosis of depression. Okay, so the patient is going to say that, yeah, doctor, my mood is a 5 on 10 or 4 on 10, or a 3 on 10, okay, depending on whatever the mood of the patient is. All right. Then you would ask that, have you been feeling low recently? Again, a very vague question, but important for depression, because the people who are undergoing depression, they do feel low. Okay, and then you can ask about the other symptoms of depression. Okay, you can ask about that. Okay, are you having any sleeping problems? But let's suppose if the presenting complaint was insomnia, then do not ask this question again. Okay, that means that you're not paying attention, because the presenting complaint was insomnia, and now you're again asking that, by any chance, are you having any sleeping difficulty? So just make sure that you're not repeating the symptom that was presented to you earlier on. Okay, so just explore the other symptoms, and one single liner questions that, okay, by any chance, are you having difficulty in sleeping? By any chance, are you feeling tired? Or any weight loss you have recently noted? You have any loss of libido that you have noted recently? Are you having any difficulty in concentration and concentrating on your daily work? Okay, so the other symptoms of depression, okay, just single liners, or do not need to go into a lot of detail. That, okay, let's suppose if the patient is also having insomnia, and it wasn't given earlier on. Okay, let's suppose the patient presented to you with tiredness in the first place, and then you find out and you figured out that, okay, this is depression, and now you ask about the other symptoms, that do you have any by any chance, do you have any difficulty in sleeping, and the patient says yes. So do not just open up the book and open up the questions that you need to ask to explore insomnia. Okay, because insomnia is not the major problem. Insomnia is a symptom of the problem that is at hand, that is depression. Okay, so exploring further on these symptoms would not be the wise thing to do. Okay, so make sure that you uh, like uh, just ask those single questions, just to make sure whether or not these symptoms are present or not, and this will help you only further solidify your diagnosis. Okay, no details. All right. Then in the previous lectures, I told you, like in the schizophrenia lecture, I told you that the psych specific history. Okay, there are three important components that you definitely need to ask whenever you are dealing with a psychiatry session. That was number one, mood; number two, hallucination; and number three, the thoughts of self harm. Okay, in the schizophrenia session, the problem was with the hallucination. Okay, so you give separate attention to hallucination, and you explored the hallucination, you explored the thought insertion and deletion, etc. Okay, and then later on you asked about the mood, and you asked about the harm aspect separately. Okay, in the depression case, the problem is with the mood. Okay, so you have explored the mood, you have explored anhedonia and all the related symptoms of depression in a separate layer. So in the psych specific history, or the psychiatric aspect, that is exclusive, and the questions that are exclusive for the psychiatry, what are the two aspects that are remaining to ask? Number one, by any chance, do you feel the need to harm your own self? Okay, suicidal tendencies. And the hallucination aspect, that by any chance, do you see or hear anything unusual, or the things that are not seen by others? Okay, you need to ask these two questions, because as I mentioned earlier on, that in the psychiatry station, it is imperative, it is very important, it is very necessary that you always cover these three aspects somehow or the other: mood, harm, hallucinations. Okay, in the schizophrenia station, hallucination was the problem. In this station, mood was the problem. So the other two aspects needs to be explored, and just single questions, that do you feel the need to harm your own self, or do you hear or see things that are unusual, or things that may not be seen by other people? Okay, so that is what the third layer is. All right. Now let's just move on to the fourth layer, or the next layer. Okay, that is the meftosa. Sorry about that. Yeah. So meftosa, not all the meftosa aspect may be important. Okay, but some of them, may just be relevant. Like for example, the medicine. and the past medical history. Okay, this may be important because if somebody has had a depression in the past, okay, let's suppose if somebody is already taking sertraline and somebody is already, has tried to fight depression in the past as well, it's most likely that okay, their depression may just relapse. Okay, or somebody, if they might have any psychiatric condition in the past, okay, or maybe somebody have a very chronic disease that the patient may be, experiencing, then it's very much likely that they may develop depression. Okay, then there is a strong family history connection to depression, so you have to inquire about that as well, that by any chance anyone in your family have a history of depression or any mental illnesses. Okay, then the occupation, the psychosocial aspect. Okay, the occupation is like really important. Okay, why? Because this is what is going to give you the risk factor, and this is the layer when where you would be able to identify that what is the cause of depression. Okay, why is the patient depressed? Okay, what is going in his life? Okay, and that is why the psychosocial aspect and the occupation is like really important when it comes to meftosa. Okay, so the fourth layer, you should be focusing on the psychosocial aspect. Okay, so the financial stresses. By any chance, are you having any financial stresses in your life? How is your job? What do you do for a living? Okay, by any chance, did you lose your job recently? You can ask these direct questions. Okay, because still here you've already established that this is depression. Okay, and now you're trying to rule out the causes, so you can ask direct questions. Okay, then something may be going wrong with his personal life. So you got to ask about that. Who is at home? Do you have friends and family member available? Okay, again, loneliness is another major cause of depression. Okay, then you got to ask about a certain risk factors, that any loss of recent family member. Okay, and the loss means it can be death, it can be somebody going away, causing separation anxiety. Okay, like there would be cases when a young man would be coming to you extremely depressed. Why? Because he would have gone through a divorce recently. Okay, so any loss of recent family member. Okay, or any loss of pet. Okay, pets are like really close to the people in the UK. Okay, so you got to ask about that. Okay, any loss of pet, any loss of recent family members. Okay, and if you're not able to ask direct questions. Okay, and if you're unable to rule out these 4 to 5 different risk factors like financial stress, job, loss of family member, loss of pet. Okay, not having any friends and family around. Okay, then you can just ask a very open-ended question as well at this stage, that any significant event that has happened in your life that may have changed your life, that may have changed the way that you're thinking, that may have affected your mental well-being, that you would like to talk about. They may talk about it. Yeah, doctor, like my business just collapsed, and somebody went away from my life. My girlfriend just died, or anything. Okay, that may be causing the depression. All right. So these risk factors are like really important. Okay, you need to keep this in mind. All right. So this was what the 4 layers of depression was. Okay, the most complicated layer is the first layer. You need to master this. Okay, make sure that you have these steps there in your mind. Okay, now as you can see in the anything else aspect. Okay, I haven't shared it and I haven't discussed it yet. Okay, there is a reason for it. Okay, I'll just highlight it for you right now. Okay, and I'll discuss it now, and why these questions and when these questions would be important. Okay, so in the depression case, there is a variant. Okay, like there are different variants of depression case. Like I told you, it can present with insomnia, tiredness, weight loss. Okay, uh, and there is a very strong possibility that you may find a case of postnatal depression. All right, so we are aware of what the postnatal depression is, but there is a variation. Okay, there is another variation when it comes to postnatal depression. So read the 2 case notes that I mentioned over here. Let's just go through it one by one. The case note number one: you are an FY2 in GP surgery. A 25-year-old lady, Emily Cooper, has made an appointment to see you because she has been in a low mood for 1 month. Okay, this is important. She is in a low mood for how many months? 1 month. She delivered the baby 4 months ago. All right, that is one scenario. The other scenario, she is the same lady, but she is in a low mood for 4 months and she has delivered a baby 4 months ago. Okay, so in both of the cases, Emily Cooper is in the postnatal period. Okay, in both of the cases, she is in the postnatal period. But the first case, the depression in the first case will not be defined as the postnatal depression. Okay, however, the second case would be defined as the postnatal depression. Okay, and I'll tell you why. Because the criteria to diagnose postnatal depression is that it needs to be in a continuous manner. Okay, so postnatal depression is defined as a low mood continuously after birth without any normal mood, without any period of normal mood. Okay, and that is something which you need to identify and which you need to have in your head. Why? Because there is a very strong possibility that you may find a scenario like this in the exam, and you're going to see that, okay, Emily Cooper, she just gave birth 4 months ago, she's depressed since 1 month, and then you take the history, you come to the diagnosis, and then when you're explaining the diagnosis, you end up saying that, okay, from the chat that we have had blah 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 blah, and we call this condition as postnatal depression. But no, it is not postnatal depression, it is just depression. Okay, so a very very small margin of error that is there. Okay, a very very thin line between postnatal depression and depression in a woman who is in her postnatal period. Okay, so if you end up saying postnatal depression, you would not get the mark for diagnosis, unfortunately. Even though you have diagnosed it as a case of depression, and you have taken the flawless history, you have taken you have done a great data gathering. Okay, you have even managed the patient really really well as per the IRMAS protocol. Okay, you've addressed the concerns as well, everything was great, but still you're not scoring a 4 on 4 in the management part. Why? Because your diagnosis was not right. You labeled depression as postnatal depression. Okay, so make sure that you see if it's continuous. Okay, if it's the depression, if the low mood is continuous from the time of birth, or if there was a period of normal mood in between, and then the low mood started. Okay, so very very important aspect. This variation that I wanted to teach before the postnatal depression, before I talk about the postnatal depression. Okay, now let's move back to the layer number 4. Okay, so these questions of anything else. Okay, these are the questions that you need to ask whenever you find a lady that is in her postnatal period. Okay, what are you going to ask? And now the basically the reason for depression, okay, the risk factor for depression that we were trying to rule out in the psychosocial aspect, that would change. Okay, and what would be the different risk factors? Number one, difficult pregnancy. So you want to ask, can you please just tell me about the birth of your child? Was it normal? Did you have any difficulty during your pregnancy or during your delivery? Okay, number one. Number two, was this child planned or unplanned? Okay. Number three, do you have a supportive partner? Because a lot of women who do not have a supportive partner, when they end up conceiving, uh, they start hating the idea of having the child. Okay. Number two, number three, number four. By any chance, are you a single mother? Do you have a partner? Does your partner support you? Okay. Single mothers often have a higher risk of developing postnatal depression, so you gotta ask about that as well. Okay. Then this question is extremely important in postnatal depression case. Okay, how is your child doing nowadays? Is your child completely all right? Is your child safe? Okay, how is your relationship with your child? This is a very important question. And why do I say this? Because the patient with postnatal depression, okay, they wouldn't just have the thought of harming herself. Okay, they wouldn't just have this problem. Okay, they may be hallucinating, they may have the tendency to harm the child as well. Okay, so you have to ensure the baby's safety. Okay, and this is something that I've mentioned over here as well. Always remember to check if the baby is safe. Okay, and if you're not checking that, then go and do a floor station. You still won't be able to pass the session if you're not checking the baby safety. Okay, it is extremely important to make sure that the baby is all right. You are addressing this concern, you are bringing this thing up, that is your child all right, is Joshua doing completely fine, or how is your relationship with the child. Okay, so this is like very important aspect, and that you need to share, and that you need to like cover. Okay, so yeah, that's pretty much it for the layers and for the questions that you need to ask, and how the depression cases would be presenting, what would be the different variants. Okay, and what are the key points where the simulator is going to confuse you, or the GMC is going to confuse you. Okay, all right, yeah. Before I talk about all of these things, let me just share with you how you're going to explain the diagnosis. Okay, it's very simple. That from the chat that we have had, and from my examination finding, you might be having the condition of the mind. I told this thing before as well. You're not going to say brain. You're not going to say mental illness. Okay, you're going to use the word mind, that is characterized by low mood due to the lack of happy hormones in our brain. That is what the pathology of depression is: lack of serotonin. Okay, lack of dopamine. So you just got to say that, okay, you are having a condition of the mind that is characterized by low mood, and due to the lack of happy hormones in our brain, and we call this condition as depression, which is a pretty manageable condition. Okay, and the explanation would remain the same, but the only difference that would happen in the postnatal depression diagnosis is that, okay, from the chat that we have had, and from my examination findings, you have a condition of the mind that commonly presents after a pregnancy. Okay, that commonly presents after a pregnancy, that is characterized by low mood due to the lack of happy hormone in our brain, and we call this condition as postnatal depression. Okay, that is how your explanation would change slightly. Okay, very slightly. All right, yeah, so that is what the explanation part is. Then when to admit, we have discussed this thing earlier on as well, in the previous lecture, that whenever a psychiatric patient comes, what are the parameters you need to look onto when you have to admit the patient. Okay, just one thing that I would like to like share is the crisis home resolution team. Okay, so a depression patient, whenever you are discharging a depression patient, and whenever you are sending a depression patient home, what is very important is the amount of safety netting that you do. Okay, so this the in the IRMAS protocol, in the IRMAS protocol, you need to make sure that the safety netting is done very aggressively. Okay, the safety netting and the advices. Okay, these two aspects becomes like very important. Yes, the medical management is there. You gotta start the patient on serotonin. Okay, the referral is there, that you may want to refer the patient to psychiatry if the depression is like really severe. Investigations are like just the basic investigations, the baseline investigations. So that part is like always there, yes, but the advices and the safety netting. Okay, you need to give a lot of advices, that, okay, make sure that you have the support available. Try to like involve yourself in those activities that used to give you pleasure before. Try to go on a walk, try to go to the gym. Make sure that while you're experiencing all of these thoughts, you're not driving. Okay, you're not taking extra work. If you're stressed at work, try to maybe take a vacation. Try to take some off from your work. Okay, so that is all the advices that you're going to give. Okay, like, and it needs to be given in a very reassuring tone. It needs to be given in a very supportive tone. Okay, then another thing that comes in the advices, which is not mentioned here on the screen, but I am telling it to you, so please note it down. Those people who are going through financial stresses, and those people who have some problems with their finances, okay, they needs to be referred to the Citizen Advisory Bureau. Okay, so I'll just write it down for you so that you have an idea what the Citizen Advisory Bureau is. So Citizen Advisory Bureau is basically a solution that NHS offers to the people who are struggling financially, who have some financial struggles. So if somebody has lost a job, if somebody is having difficulty in managing their finances, you can refer this them to the Citizen Advisory Bureau, and they're going to help them financially and provide them with financial assistance on the basis of their need. All right. The next aspect that I was talking about is basically the safety netting. Okay, so you need to make sure that you are safety netting the patient very aggressively, and the safety netting part is done in the right way, because the patient of depression, if you're discharging that patient home, you need to talk about the risk of suicide, you need to talk about the risk of self harm, and you need to tell the patient that, okay, if you ever develop any need, any feeling that you want to harm yourself, or if it's a case of postnatal depression, then you may talk about that, okay, if you ever feel the need to harm your baby, and if you start experiencing any hallucinations, like for example, if you start experiencing to see and listen things that are not usually there, then you may want to seek medical help. Okay, and if you can come to the A&E, if you can go visit a nearest GP, you can do that. But other than that, there is something called the crisis home resolution team. Okay, you need to tell the patient about it. Okay, this is basically a solution that is initiated by the NHS to provide urgent mental health support. Okay, and those patients who are undergoing depression, those patients who have the thoughts of harming their own self and having psychiatric issue, okay, they offer home based treatment as well. They have got counselors, they've got medical services available, they've got psychosocial therapy available that they go and deliver door to door as well. Okay, so you can mention about the crisis home resolution team. And there is something called the crisis card, also known as the NHS crisis card. Okay, uh, it is given to the patient who have some mental health illness or the other. Okay, and it contains details about the emergency contact, what type of mental illness they are having, what is their preferred coping strategy, so that if a patient goes into that depressive episode, goes into that psychiatric episode, the other people who are there with him, and the people who are looking at the card, they know that what to do and what are the things that can help this particular patient. Okay, so you need to be aware of these things, and you need to offer these things. All right, so that's pretty much it from the depression aspect. Okay, if you've got any queries, if you've got any concerns, if you've got any questions that you need to ask about, please drop them down in the comment box below, or reach out to the social media details that are mentioned over here. And if you want to have a personalized mock with us, then scan the QR code, go to the website, fill in a Google form, and my team will reach out to you regarding that. So see you in the next lecture.